Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be talking on one of the odd topic, but once in a while you can come across this particular group of people we call scleroderma or systemic sclerosis. So we'll be discussing today on that topic. So scleroderma or systemic sclerosis is one of the disorder which involves skin and multiple other organs, and once in a while you will see such patient. Recently only we have seen one patient, so I thought I should discuss with you. So I'm putting this particular. The meaning is very simple. Sclerosis is fibrosis and derma means skin. So it is a fibrosis which is setting in the skin, we call as a scleroderma. And when it involves almost entire body with multiple organs, we call as systemic sclerosis. So by definition, when we say systemic sclerosis or scleroderma, it is multi-system disorder which is characterized by functional and structural and abnormalities which is leading to fibrosis of skin and internal organs. It is immune system activated, and basically it is one of the variety of autoimmune disorder. And there are two classical things which is very common. One, tight fibrous skin, which is very commonly affecting the facial part of it, and it is associated with involvement of the finger skin, that is tightening of the skin over the fingers, which leads to contractures and very frequently Raynaud's syndrome. So we had one patient who came with Raynaud's syndrome and there was facial skin involvement. So it was a case of scleroderma, we call systemic sclerosis. We'll be discussing what are the different varieties which you come across in sclerosis or scleroderma. So it is a multi-system collagen vascular disorder, means it is involving collagen tissue as well as the blood vessels of unknown etiology, means it is an autoimmune variety characterized by fibrosis of the skin and involvement of internal organs. ACR definition of systemic sclerosis. So they classify the criteria. They call major criteria, minor criteria. Major criteria is proximal scleroderma, and minor criteria includes sclerodactyly, digital pitting scar or the scar or loss of substance from the finger pads. So it is involvement of the finger, and bibasilar pulmonary fibrosis. Either one major criteria or two major, two minor or more minor criteria for the diagnosis. So either you require two minor criteria or more than two minor criteria or one major criteria for diagnosing systemic sclerosis. We had this criteria, that is involvement of the finger, plus there was little amount of sclerodactyly. So two minor criteria were there, and there was involvement of the skin, proximal scleroderma. So it was classical scleroderma. So in a minor criteria, sclerodactyly, pitting scar or loss of digital pads, and bibasilar pulmonary fibrosis. And as far as the major criteria is concerned, proximal scleroderma, that is proximal to metacarpophalangeal joints. So this is a very important criteria. So if any person who comes to with that, it includes a major criteria, and it is accepted by American College of Rheumatology, or with short form we call ACR criteria. So one major or two minor. Also, American College of Rheumatology and even European leagues. For classification of systemic sclerosis, they have put certain things. That is involvement of the skin thickening of the finger of both ends extending from proximal to metacarpophalangeal joint, which gives you 9 score. Skin thickening of the finger only on the count of fingers higher score, that is puffy finger sclerodactyly, that is given 2 and 4 score. Fingertip lesions 2 and 3. Tip ulcer 2. Fingertip pitting scar 3. Telangiectasia 2. Abnormal nail fold capillary 2. Pulmonary fibrosis and pulmonary hypertension. If there is a pulmonary hypertension 2. Interstitial lung disease 2. Raynaud's phenomena 3. And laboratory parameter wise, anti-sclerotic 70 antibody or anti-RNA polymerase antibody and anti-centromere antibody. So these three are the common tests. So if anti-centromere antibody is positive, 3 points. Anti-SCL 70, 3 points. RNA polymerase 3 points. So these are the different points given by American College of Rheumatology. And if the total score, adding all, so depending upon that particular score, you give them a probability or definite variety. So depending upon that, so if the score is more than 25, it is straightforward in favor of definite sclerosing, or we call systemic sclerosis. So these are major criteria: proximal scleroderma, symmetrical thickening, tightening, induration of skin of fingers and proximal to metacarpophalangeal joints, and changes may affect the entire extremity, face, neck and trunk. This is included in major criteria. In minor criteria, sclerodactyly, digital pitting, loss of substance from the finger pads, bibasilar pulmonary fibrosis. There is one more variety where they call very early diagnosis of systemic sclerosis, or called VEDOS, is by European groups, where they include puffy fingers, Raynaud's syndrome, antinuclear antibody, scleroderma specific antibody, and nail fold capillaroscopy. So they include these 4 criteria, and depending upon that, they label early diagnosis, out of which a very specific, that is antinuclear antibody and specific antibody, goes more in favor. So there is first degree VEDOS red flag, that is Raynaud's phenomena with puffy finger, and if there is capilloscopy positive, and serology wise, if ANA, ENA, topo I and anti-ceruloplasmin antibody, that is given 1 level, further diagnostic procedure should be done, and if esophageal manometry or imaging evidence or HRCT suggests bibasilar pulmonary fibrosis and esophageal manometry suggests esophageal involvement, decreased motility, it goes in favor. We already mentioned this, that rheumatologist criteria: Raynaud's phenomena, swollen finger with skin thickening of hand and face, esophageal motility syndrome, and involvement of other organ like small intestine, pulmonary fibrosis, pulmonary hypertension, cardiac involvement, kidney involvement, etc. are taken into account. Basically, it is classified into three common variety, that is localized variety, limited variety, and diffuse disease. Diffuse disease is given a name scleroderma or primary systemic sclerosis. It is also called scleroderma sine scleroderma, and that involves skin extending from proximal extremity. So it is starting from proximal to distal. So proximal extremities will be extending to proximal, right from the tip of the finger, etc. In a limited variety, there is one classical syndrome which is called Crst syndrome or Crest syndrome, which is characterized by calcinosis, Raynaud's phenomena, esophageal motility syndrome, sclerodactyly, and telangiectasia. While in a localized variety where there are focal patches, very small area, it is called morphia. And if it is involved in a band-like linear area of thickening, then it is called linear scleroderma or coupe de sabre. These are the two common variety which are being included. There are other also which are included in localized scleroderma. As we pass on, we'll be mentioning some of those. So divided into diffuse, limited, and systemic. We already mentioned that diffuse, that is DC, is for diffuse cutaneous sclerosing scleroderma. So abrupt onset, where you get Raynaud's phenomena is common. In a diffuse variety, Raynaud's phenomena is very common. Thickening of the trunk, acral skin edema. Earliest features will be pulmonary fibrosis, renal involvement, and also you will have different parts of the skin involvement. In a localized variety, it is a skin induration mainly limited to hand, face, or feet. And there is a classical variety we call as a Crst Syndrome, where Raynaud's phenomena may be present. So this Raynaud's phenomena is for R. While systemic sclerosis, where you get visceral involvement without skin involvement, that is systemic sclerosis sine scleroderma. So you get a diffuse limited variety, localized variety, and diffuse variety. So diffuse variety, limited variety, in limited variety you can have Crest syndrome and you can have a localized scleroderma. And in systemic sclerosis, it is visceral involvement without skin involvement. So in a diffuse variety, you get diffuse systemic sclerosis, limited systemic sclerosis, and overlap syndrome. While in localized variety, morphia and linear scleroderma. And again, there is one more variety is called progressive hemiatrophy. That is called pansclerotic variety and deep subcutaneous variety. And this progressive hemi variety is also called as en coupe de sabre. So these are different words which are being utilized. In overlap syndrome, it can be scleroderma with rheumatoid arthritis or with SLE or dermatomyositis. Any one of this combination. Scleroderma with RA, scleroderma with SLE, or scleroderma with dermatomyositis. That is called overlap syndrome. As far as the etiology is concerned, there is one predisposing factor we call as a genetic, where there is a defective immunoregulation, and because of that we come across abnormality we call humoral immunity is disturbed. There is a hypergammaglobulinemia, autoantibody production, anti-nuclear antibody will be present in almost 95% of the people. It will be positive in 95% of people. And even this is also present in case of rheumatoid arthritis, scleroderma, and polymyositis. There are some environmental factors which are responsible, like silica dust, organic solvent, biogenic amines, urea formaldehyde, PVC, or also called the polyvinyl chloride, rhabdoid, bleomycin, L-tryptophan, silicone implant, etc. These are some of the factors which can predispose to scleroderma. So, silicone exposure, silicone breast implant, aniline phase contaminated rapeseed oil, vinyl chloride or we call polyvinyl chloride PVC, eosinophilic fasciitis, bleomycin, etc. And this genetic factor we have already mentioned. Per million it is only 4 to 12 cases. Age from 35 to 65. Female to male ratio is almost sometime 12:1. So female are more prone as compared to male. There is a definitely genetic background, so there will be a strong family history. As far as pathogenesis is concerned, there is uncontrolled, irreversible proliferation of connective tissue along with vascular involvement. So there is an abnormality in a proliferation of collagen tissue. There are some basic function of collagen tissue. So because of abnormal proliferation, these are being disturbed. So I'll show you one or two slides. There's some triggering factor which will give rise to immunological imbalance, which will give rise to immune response, cytokine production, cell recruitment, growth factor production, and fibrosis. And also there are triggering factors which can give rise to ischemic pathophysiology, where there is a chronic endothelial cell injury with vascular compromise, chronic ischemia to the tissue injury, chronic tissue repair, and fibrosis. So both may be playing a role together in case of a systemic sclerosis. So they say that there's a vascular injury. Secondary to vascular injury, there is endothelin production. That endothelin production produces obliterative vasculopathy, tissue hypoxia, and secondary to tissue hypoxia, there is a fibroblast activation, and there is a collagen connective tissue accumulation, which will end up with fibrosis. As well as, because of endothelin production also, there is a fibroblast activity. Secondary to fibroblast activity, there will be excessive proliferation of collagen tissue and it will end up with fibrosis. Also because of endothelin activity, it will activate cytokines TG alpha, what we call as a growth factors, which will again increase fibroblast activity. So this is a chain cycle. There will be stimulation of leukocyte recruitment, which will give rise to formation of an autoantibody, which can again stimulate fibroblast activation as well as a vascular injury. So this is a vicious cycle which goes on, and that will end up with fibrosis involving skin and blood vessels. So it is a multifactorial. There is a vascular injury which will activate injured endothelium, which will activate platelet. Platelet will release different mediators which will give rise to thrombosis and occlusion of the involvement of the blood vessels leading to thrombosis, or platelet activation can release growth factor leading to fibrosis. Fibrosis will increase collagen type 1, which will again activate platelet factors and platelet. Also platelet will activate leukocytes, which will increase inflammation and autoimmune, which will release cytokines and produce again a damage. So these are multiple factors: vascular injury, fibrosis, inflammation, and autoimmunity. And platelet play a very, very major role in that. Again, same genetic susceptibility, external stimulus, cellular immunity activation, immune mediator release. Now both this will produce collagen synthesis and organ damage. It will also stimulate fibroblast proliferation. It will also stimulate endothelial injury. Secondary to endothelial injury, fibroblast proliferation and organ damage. And end organ damage will also give rise to immune mediated release, etc. So this will continue. And external stimulus like Raynaud's phenomena can also stimulate the endothelial injury, and that can also set up again fibroblast proliferation, etc. So endogenous or exogenous pathogens which stimulates antigen preceding cells, stimulation of CD4 and T cells, production of cytokines, growth factors, stimulates fibroblast activity, increase collagen production, thickening of intima, vascular damage, narrowing of the lumen, ischemia, and secondary to ischemia, you start getting a damage to the portion which is being involved, and the most common portion which is being involved is fingertips. We have already mentioned in the different types: localized variety, limited variety, diffuse variety, and scleroderma, sine scleroderma. So in a localized variety, two common morphia and linear scleroderma are also called. There is one name given, coupe de Sabre. In limited, this is Crst Syndrome, and in diffuse, it involves skin extending up to proximal extremity. So it is a diffuse variety, or also called as primary systemic sclerosis. While in scleroderma, sine scleroderma, it is multi-organ involvement without skin involvement. So this is very odd, but you do come across that. When you get this distal involvement, it is limited cutaneous variety, and when entire body gets involved up to proximal, it is called diffuse cutaneous scleroderma. So there is one called as pre-scleroderma. This is involvement of the organs. Limited scleroderma, it is mainly involving a portion of the skin like morphia or linear variety, and diffuse will involve skin plus organs. So in a diffuse variety, we come across Raynaud's phenomena, skin involvement, musculoskeletal involvement, GI tract, CVS, respiratory, kidney, etc. In scleroderma, sine scleroderma, where you will get more of GI tract, cardiopulmonary and renal involvement without skin and musculoskeletal involvement. Pre-scleroderma also you get only Raynaud's phenomena without any involvement of the skin, musculoskeletal or GI tract. So difference between these two, here you get involvement of organs, skin and musculoskeletal system is not involved. Raynaud's phenomena invariably may be present, while here it is always present. So only finding you come across is Raynaud's phenomena. So Raynaud's phenomena will be present in all the four variety: limited variety, diffuse variety, and again in limited variety we have already mentioned, that is localized and Crest syndrome. So in a limited variety you will have a Raynaud's phenomena, skin involvement of musculoskeletal. It is just like a diffuse variety, where classical you can have involvement of the skin with organ involvement, but kidney involvement in that variety is not common, we call rare, and skin involvement is mainly focal. If it is involving a small portion, we call as a morphia, and when it is a band form, we call as linear variety or band form variety. So these are the different presentation what you come across. We'll be discussing together as common. So in a scleroderma, you get autoimmune connective tissue disorders. Male to female ratio may be right from 1:4 up to 14. It can start at any age, right from 30 to 50. Smoking increases the risk of scleroderma. Crest syndrome will consist of calcinosis, Raynaud's phenomena, esophageal motility, sclerodactyly, and telangiectasia. So that is that particular organ involvement. Or you can have also involvement of eye and mouth, where you come across what we call as a Jogarin Syndrome. P is for autoimmune disorder resulting in a vascular damage. There is an organ damage due to fibrosis secondary to vascular pathophysiology. Very commonly it involves kidney, pulmonary complications. As far as antibody is concerned, in a limited variety, in a limited cutaneous scleroderma, there is ACA antibody positive. In 40% of the people, we call anti-centromere. 40% it is present, while in case of a diffuse variety, there is anti-sclerotic antibody is present not in 70%, almost we say 90%. And T is hard to treat, that is immunosuppression does not give a good results. Even after using of cyclophosphamide, it does not give a good results. Renal impairment, usually we treat with ACE inhibitor. Esophageal motility, we treat with proton pump inhibitor. And pulmonary hypertension is treated with calcium channel blocker. And in heart, you will have to go for a ECG, and depending upon the involvement of the heart, you will have to treat. Usually prognosis is poor, so there is hardly any treatment left. So scleroderma, very commonly, etiology is not known. There are some environmental factor, there is a genetic factor, and there may be overlapping disease like rheumatoid arthritis, SLE, or even polymyositis. You can have a localized variety like morphia or linear variety, and systemic sclerosis, which can be limited or diffuse variety. In a localized variety, morphia, where it is usually involving a small portion of skin, mainly face, neck, etc. In a linear variety, it is usually in a band pattern, very commonly affecting face or limbs, maybe involving head, which is very commonly called as ant coupe de sabre, and in a limb it can be involving. So this will be what we call as a localized variety. In a limited variety, there is a slow progression, little or no skin thickening, musculoskeletal involvement is less likely. It mainly gives rise to what we call as a classical Crest syndrome, where you get a calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia. So this is very, very common. In this particular, there is increased chance of osteoporosis, increased chance of celiac sensitivity. There may be overlapping syndrome like Jogarin, SLE, polymyositis, RA, etc. And there is an increased chance of cancer also. In a diffuse variety, it is more rapid onset and progressive. Rapid skin thickening, muscle and tendon involvement, internal organ involvement, kidney is very commonly involved, and there is a positive antibody that is called anti-SCL, anti-scleroderma 70 antibody. While here, anti-centromere antibody may be positive in 40% of the people. This is positive in almost 70 to 90% of the people. So we have already given a difference between limited and diffuse variety here. We have already given. This is little bit in more detail. If you want to undergo, ANA will be positive in both. Anti-nuclear antibody will be positive in both. In limited variety, skin involvement and what we call as a musculoskeletal involvement is less, while in diffuse it is more. Raynaud's phenomena is there in both variety. Renal involvement is very rare in limited variety, while renal involvement is quite common in case of a diffuse variety. So do keep it in mind and try to differentiate between the two. In a subset of systemic sclerosis, this is limited and cutaneous. Again, same skin, Raynaud's phenomena, pulmonary fibrosis, pulmonary hypertension. Renal crisis will be more common in diffuse as compared to limited. It is absolutely rare. Calcinosis cutis is more common in limited variety, very uncommon in diffuse variety. And antibody anticentromere is positive here, while antipoisomere, topoisoisomere, or it is also called antisclerotin 70 positive. Same difference again mentioned in limited and diffuse variety percentage wise. What is more involved? At your leisure time you can go through. Along with all these features, person may complain of weight loss and fatigue. Skin involvement is common. Musculoskeletal involvement is common. These two are more common with diffuse rather than limited variety. Pulmonary involvement is more common in again diffuse variety. Kidney involvement is more common. GI tract, that is GI tract involvement with calcinosis, telangiectasia, Raynaud's phenomena is more common in case of Crst syndrome, and that is seen in a limited variety. And that cutate or a calcinosis cutis, that is calcinosis in the skin part of it, that is not commonly seen in a diffuse variety. So diffuse is more rapid skin involvement. Capilloscopy will relieve dropouts, very typical. Capillary dilatation with dropouts is very classically seen in a diffuse variety. And organ involvement, or we call renal, lung, myocardium, GI tract, is within first 3 years, quite common. An antibody is positive. We call anti-RNA polymerase is also positive. And this is called anti-Scleroderma 70 positive. Systemic sclerosis is rare, heterogeneous, slow motion disease with small window of opportunity to fundamentally change the course of the disease. It is absolutely difficult. You get even prayer signs. This is prayer sign. This is Raynaud's phenomena. This is skin thickening. This is esophageal involvement. This is pulmonary fibrosis. So this is Raynaud's phenomena, acroderma or sclerodactyly. This is lower lobe fibrosis, kidney involvement, heart involvement, Raynaud's phenomena, typical skin involvement. You can see the typical skin involvement, very, very classical. While in a limited variety, it is more gradual. Raynaud's phenomena may be present quite before you start getting skin involvement. Skin involvement is not very common. Maybe around the perioral region, we call pursing of the lips. Skin involvement distal to the elbow and knee. Capillaroscopy will dilatation of loops but without dropouts. The systemic involvement is limited to very few organs, where you can have a lung involvement and GI tract involvement. Renal involvement is very rare, which is more common in a diffuse variety. Anticentromere antibody will be present in almost 70 to 80% of the people. This is classical Crest syndrome, we call calcinosis or calcinosis cutis, Raynaud's phenomena, esophageal motility with acid reflux, sclerodactyly, very typical, and telangiectasia. This will be more common in Limited variety. So typical Crest syndrome, this is calcinosis cutis, Raynaud's phenomena, pulmonary fibrosis, and you can get telangiectasia. This is sclerodactyly. This is sclerodactyly, calcinosis cutis, Raynaud's phenomena, esophageal motility. Typical, you can see this calcification. Calcification can be seen on an X-ray also. This is called calcinosis. In a nail port, you can see the capillary dilatation and there is a dropout. Dropout will be seen in a diffuse variety and dropout will not be seen in a limited variety. There is an overlap syndrome where you can have a systemic sclerosis with SLE or RA, polymyositis, and another we name is Jogarin syndrome. This is classical. You can see that this is a linear variety. You can see fibrosis involving this part of the skin. You can see this is involvement. While here, this is the portion which is being involved. So, morphia, that is involvement of the skin in a local part. You can have a pansclerotic morphia, where it is little more diffuse. Linear scleroderma, or also called as en coupe de Sabre. This is en coupe de Sabre. And you can have a progressive hemifacial atrophy. Sometimes you come across that typical variety, in which you got a hardening and thickening of the skin, discoloration, overshaped patching, linear patches, loss of hair and sweat glands. This will be seen in a skin. You can see this typical. This is discoloration. This is localized involvement. You can see this is a localized involvement. Localized involvement. You can have multiple different varieties. This is involvement of the skin. This is involvement of the skin. You can see this. But this is involving the entire body, so it becomes generalized. You can see this is typical involvement of the skin. Chest, lower limb, upper limb, etc. are involved. This will be generalized variety. This is linear variety. This is linear variety. This is, you can see, linear variety. So this is linear variety. Again you can see typical only in linear. Only this much portion is involved. This is called linear scleroderma. This is, you can see, again a linear variety. This is involvement of the face. Again linear. This is linear variety. This is almost half of the face getting involved. This is linear scleroderma. You can compare the two. This is linear, only in one part of the body. There is a hyperpigmentation. You can compare these two. There is a muscle atrophy. This is again a linear scleroderma, only involving one side of the body. This is one along linear side. Usually there are two varieties what we come across: diffuse variety and limited cutaneous. And you can see the progress in a limited cutaneous. Slow progressive. And almost then it remains nearly same even after 20 years. While you can see here, it is rapidly progressive and then involving skin along with GI tract, lung, heart, kidney, etc. And there is a rapid deterioration. You can see that deterioration. Well, this remains nearly same. These are different skin features. In hand, you can get Raynaud's phenomena, swelling of the finger, toes, non-pitting edema. We call Prayer's sign. This is typical Prayer's signs because of reduced hand motility. Fingertips will have a pitting ulcer, deep ulcer, and you can have even loss of finger pads. You can see calcinosis, then we use the word calcinosis cutis. You can have a tightening of the facial skin, microstomia or pursed lipping, we call tight lips, or it is also called as a microstomia, where the opening of the mouth is becoming small. On the face, you can see telangiectasia, and there is one word utilized, salt and pepper appearance of the skin due to hypopigmentation and hyperpigmentation. The skin is usually dry and itchy, and there is a reduced hair and reduced sweating. So skin is thick, shiny, tight, crease disappears, there is hyper and hypopigmented patches, hair loss and decreased sweating. Typical, very, very typical face. And along with that, you can have a resorption of a terminal phalanges called as a acro-osteolysis. And if there is involvement, calcium deposits with involvement of other organs, and that in deposition is of calcium hydroapatite crystals. So that is Crst syndrome. We already mentioned before, C for calcinosis, R for Raynaud's phenomena, E for esophageal motility, S for sclerodactyly, T for telangiectasia. So these are all the findings you can see. And on the face, when you see that, it is typically described as Moskop appearance. So go through your leisure time. This is again typical. You can see that this is tight lips producing small opening, Moskop, pinched nose, pursed lip, cannot evert eyelids, lip thickening and retraction, immobile face, etc. Typical facial changes. Pinched nose. This nose is pinched. So that is described as typically. You can see here. This is pinched nose. And that is described as a Moskop face appearance. Facial changes, you can see typical facial changes. You can see thickening of the lips. This is involvement with the chest as well as neck region. Typical, you can see typical fibrosis. Again, typical nose. These are facial changes. Very classical changes. Skin thickening, sclerodactyly. This is sclerodactyly. This is sclerodactyly. This is salt and pepper appearance. Hypopigmented, hyperpigmented. Sclerodactyly, typical. And you can see facial changes. This is salt and pepper appearance. Calcinosis cutis. This is digital ulcer leading to even necrosis, and then this will fall off. And there is a osteolysis which is going on. This is typical sclerodactyly. It is also called as acro-osteolysis. Secondary to that, bone resorption takes place, and it is acro because of involvement of the blood vessel supply, blood supply. You can see this portion of the bone has been osteolyzed. Typical nasal pinch. Calcinosis, cutis, telangiectasia, sclerodactyly, salt and pepper appearance, typical facial appearance, typical lips, very classical. Swollen hands, edematous but non-pitting, Preyer's sign, sclerodactyly. You can see this salt and pepper appearance. Again, scleroderma, skin induration. You can see the terminal finger getting taper out, and you will have a acro-osteolysis, acrosclerosis. See this tip of the finger, lost. This also. Salt on paper appearance, Raynaud's phenomena. We'll be having a separate lectures on Raynaud's phenomena and Raynaud's syndrome, etc. Together, we'll be discussing that particular part. Typical three phases: pallor, cyanosis, redness. It can be primary, it can be secondary. You will have a nail fold microscopic appearance where you will see capillary dilatation and dropouts in diffuse variety, capillary dilatation only in case of a systemic variety or a limited variety. These are all the findings you can come across in case of a primary Raynaud's. These are in secondary Raynaud's. So go through your little. We'll be discussing in a Raynaud's. This is typical Raynaud's phenomena. You can see cyanosis. This is pallor. This is cyanosis. This is pallor. Again, you can see cyanosis. This is pallor. And you can see a blood vessel spasm. Very classical. Telangiectasia. Very clearly you can see that. You can see this telangiectasia. Very commonly seen on lips, tongue, face. Occasionally over the fingertips. Local disruption of angiogenesis, which blanches by pressure. That is typical telangiectasia. This is nail fold capillary. This is in normal. You can see normal capillary. You can see this capillary are dilated. And if you see dropouts, suddenly there is no further, then that is very common in diffuse variety. You can see here, these are dilated and then there is a dropout. While if you see dilatation without dropouts, this is dilatation, but there is no dropout, then it is more common in case of a localized variety. There is some skin core which can be utilized. You can utilize that skin core to find out the severity of involvement of the skin. In a musculoskeletal involvement, you can have a carpal tunnel syndrome, generalized arthralgia, stiffness, joint mobility is reduced, PIP joints are more commonly involved, wrist can be involved. You can have involvement of the tendon producing friction rub, joint inflammation is reduced, muscle weakness may be because of a disuse, myopathy can be there, bone resorption we call as acro-osteolysis will be seen, particularly terminal finger will be involved, and there will be loss of distal part of a terminal finger. Mandible may be affected, ribs, clavicle may be affected. Skeletal involvement, we have already told you, you can have a terminal finger being very commonly affected because of acro-osteolytic, and more of small fingers will be very commonly involved. You will have a skin thickening, little edema like but non-pitting. This is typical acrolysis, or we call acro-osteolysis. You can see the terminal part is lost. You see this portion is lost. You will have a loss of those terminal portion, very typical. This terminal portion will be lost. Distal portion, you can see this portion, these are ulcer, digital pitting ulcer, deep ulcers, and then that ulcer can get necrosis and it can fall off, loss of the terminal part. You can see this, very typical. This is very bad variety. You can see this auto amputation, it is also called as auto amputation, deep ulcer, and then necrosis, and then auto amputation takes place. Crest, we have already shown you calcinosis, Raynaud's phenomena, esophageal dysfunction, sclerodactyly, telangiectasia. This is calcinosis cutis. This is calcinosis with acrolysis. You can see this is calcinosis and this is acrolysis. This is calcinosis cutis. Typical. And on an X-ray you can see this is calcinosis cutis. and you can have a acrolysis. R for Raynaud's phenomena, pallor, cyanosis, redness. Pallor, cyanosis followed by redness. Esophageal motility will be affected. So you will have a narrowing at the lower esophageal sphincter. You will have a GERD, and that can result into damage, and you can have even Barrett's, Barrett esophagus. Abnormal GI motility leading to GERD, quite common. S for sclerodactyly, and you will have acro-osteolysis, very typical. So flexion will be affected, contractures, even you will have an involvement of the oral skin, particularly lips, giving rise to typical difficulty in opening. And then you can have a telangiectasia, and on capillaroscopy, you will get dilated vessels with dropouts, dilated capillary with dropout, typical telangiectasia. You can see telangiectasia. See this over the tongue, over the lips, face. This is tendon friction rub, may be palpable and maybe even audible. Palpable tendon friction rubs, very easily palpable at different portion. Knee, ankle, elbow, small joints, shoulder, etc. Lung can be involved. You can have an involvement of the basal part of the lung. We call it a diffuse interstitial pneumonitis and fibrosis, mainly by basilar pulmonary fibrosis. Basilar pulmonary fibrosis, which is more common, and that can end up with pulmonary hypertension, pneumothorax, spontaneous pneumothorax, maybe pleural effusion, pleurisy, bronchiectasis, aspiration pneumonia, and very rarely malignancy. In kidney, proteinuria and renal hypertension. GI tract, esophagus, esophageal sphincter, strictures, dysphagia. Small bowel, diarrhea, malnutrition, decreased peristalsis. Large bowel, constipation, obstruction, perforation, and diarrhea. So lot number of, there is one type of typical stomach distribution, it is called watermelon stomach. Very, very typical of stomach involvement. Typical. This is endoscopic view. So it looks like watermelon, so it is described as watermelon. In small bowel, it is described as hidebound sign, or it is called stack of coin sign, accordion sign. These are the different name, three names given to this X-ray picture finding. This is stack of coin. It looks like accordion, so it is also called accordion, and hidebound sign. You can have a diverticulum in a large bowel. You can see a small diverticulum, multiple diverticulum. You can see this diverticulum. In heart, pericarditis, heart failure, arrhythmias, myocardial fibrosis. And secondary to myocardial fibrosis, it can lead to restrictive cardiomyopathy. So this is cardiac involvement, myocarditis, pericardial effusion, microvascular coronary artery disease, macrovascular coronary artery disease, bradycardia, tachyarrhythmias. Exocrine glands involvement, it can give rise to xerophthalmia and xerophthalmia, which is one of the part in case of a Jogarin syndrome. There are two words commonly utilized, limited crest and diffuse primary systemic sclerosis. And these are the findings. We had one slide before. You can go through that at your leisure time. As far as a blood test is concerned, by and large you can easily diagnose from that. And to differentiate the two variety, anti-nuclear antibody is present in both. In diffuse variety, it will be anti-sclerotic antibody will be positive, while in case of a localized variety, anti-centromial antibody will be positive. Anti-sclerotic anti-70 or also called as a DNA topiosomers antibody, but short form we call as anti-sclerosis 70 antibody, while anti-centromial antibody will be positive more in case of a limited variety. This antibody will be positive in 20 to 40% in diffuse and in limited variety only in 10 to 15%, while this is more differentiating. Almost in 90% it will be present in limited variety, anti-centromial antibody. And you will have a ANA positive and RF factor may be positive in both. So by and large the clinical picture is more important, and then comes what you call as antibody titers. So these are different antibody which are being utilized. So Scleroderma 70 antibody will be in diffuse and anti-centromere antibody will be positive in limited variety. These are the other which can be present in diffuse, while in limited anti-centromere is the main antibody which will be positive, and in overlap you can have another variety of antibody which can be present. This is more common with Jogarin syndrome, polymyositis, SLE, etc. So there are a lot of antibody. Mainly we do anti-scleroderma 70 antibody and anti-centromere antibody. ANA will be positive in almost 90% and RA factor antibody in almost 30%. You can go for a genetic HLA association and then organ involvement studies. Differential diagnosis mainly for tight skin. There are other conditions also which can produce tight skin. We call pseudo-sclerodactyly, like insulin dependent diabetes mellitus, hypothyroidism, certain drugs, overlap conditions, etc. So try to rule out those first. Vascular changes can be seen in a big list. You can see there is a big list where you can get vascular changes, skin changes, and visceral involvement. That should be also differentiated. As far as treatment of pulmonary fibrosis is concerned, mainly immunosuppression, and in pulmonary hypertension, CCB. Renal involvement, again ACE inhibitor is the first drug of choice. GI tract involvement, mainly PPI, and treatment of malabsorption, etc. should be done. In cardiac involvement, steroids for pericarditis. For arthritis, NSAID. Myositis, methotrexate is utilized, and steroid and azathioprine. For skin, ultraviolet is utilized, or you can utilize steroid for particularly renal crisis. So this is for respiratory involvement. What are the drugs which are being utilized? This is interstitial lung disease, this is pulmonary hypertension, this is cutaneous involvement, and this is digital vasculopathy, what you can utilize. You can utilize immunosuppression drugs. Most commonly glucocorticoid is very frequently utilized, and cyclophosphamide, and occasionally methotrexate. Methotrexate is not so prominent. Immunomodulation can be also utilized by using azathioprine, cyclosporine, etc. Or you can go for immune ablation by high dose of chemotherapy. Stem cell transplant are also being done, but they are on experimental ground. D-penicillamine is also utilized, minocycline, etc. Vascular therapy, you can go for ACE inhibitor, CCB, alpha blockers, etc. All those are being utilized. In GI complication, mainly proton pump inhibitor, H2 receptor blockers. Pulmonary hypertension, mainly CCB is very frequently utilized, diuretic, oral anticoagulant, digoxin, etc. Sildenafil, all those for pulmonary hypertension. Renal crisis, mainly glucocorticoids should be avoided. ACE inhibitor is the first drug of choice. For skin, steroid, penicillamine, cyclophosphamide, etc. And for telangiectasia, lesser. Raynaud's phenomena, avoid exposure to cold, quit smoking, vasodilator like CCB, particularly nifedipine, is a drug of choice. Complications, very frequently you will come across Raynaud's phenomena and gangrene. GI tract involvement will decrease the GI motility leading to GERD, and then later on it can end up with Barrett's esophagus. In lung, interstitial pulmonary fibrosis, mainly bilateral basal fibrosis, pulmonary hypertension. In heart, it can involve pericardium and myocardium, can end up with cardiac arrhythmias, pericardial effusion, and can also produce restrictive cardiomyopathy. Kidney can be involved, leading to proteinuria, and there can be renal crisis, Crst syndrome, skin and joint involvement, etc. So this is stomach involvement, esophagus, small bowel, large bowel, we have already mentioned before. Good number of people, almost 60% of the people will develop these complications. These are pulmonary complications, we have already shown you slide before. Kidney, proteinuria and renal hypertension, and also we call it a renal crisis can happen. So I thank you all for taking out time. I know your time is valuable, and I appreciate you spending some of those valuable time with me. And I hope this may be helpful. Once in a while, you might see such patients in your everyday practice. So I end my lecture here.